Good evening. First, I want to thank the organizers for the kind invitation, and thank you for the question. I will answer it in my presentation. And I'm very delighted here to be in Vicenza and to talk about the fascinating technique of extracorporeal virus elimination. I want to discuss the recent developments in an understanding of viral diseases, and I like to give you a short overview of the technique, which I think not much are common with, and maybe I show you the potential of this therapy. These are my disclosures, and just a reminder, the spread of Ebola in West Africa in 2014 was the largest known outbreak of the disease since its discovery in 1976. More than 11 people died until the virus could be contained. And Bill Gates mentioned it on the Munich Security Conference in 2017. The next 10 to 15 years, we could witness a global pandemic with taking more than 30 million people in less than a year. And therefore, he suggested an accelerated development of vaccines, of diagnostics, and new therapeutics for the emerging pathogens that this is highly in need. When we talk about viral diseases, the severe potentially pandemic viral diseases like the Ebola virus have one thing in common. It's the lipid bilayer and populated with viral glycoproteins. These glycoproteins are used for tissue tropism and for the fusion with the target cell. And these glycoproteins, as membrane-bound envelope proteins, and as I will show in soluble forms, have indispensable function for the establishment and maintenance of the infection. Blood is the main route of dissemination of virus and systemic viral infections. Some viral infections do not need any further intervention, like the common cold in adults, because the body's physiological mechanism is clears the virus. Others, like Ebola virus, accumulate specifically in the blood, and the patient remains infectious as long as the blood contains the virus. Viral antigens and toxins spread via the bloodstream to infect multi-organs like the liver, the muscle, the brain, the lung, the kidneys, and in the case of Ebola, produce hemorrhagic fever that may lead to death. Although the virus is essentially intracellular, at some stages of the life cycle, viruses and their antigens come in contact with the bloodstream, and we call it viral sepsis. And recently, it was shown that Ebola and other viral diseases also demonstrate multiple immune evasion features, including a comprehensive disabling of viral recognition by disarming interferon signaling, inactivation of antigen presentation, and a vast lymphocyte apoptosis. This immune evasion is enhanced by a process in which the glycoproteins from the envelope are shed into circulation directly from the infected cells, where they likely act as decoys to neutralize antibodies. In addition, shed glycoproteins have been shown to induce a massive release of cytokines and increased vascular permeability, which in turn leads to systemic inflammation, excessive volume loss, electrolyte disturbances, and bleeding complications. This is like septic shock-like syndrome, and ultimately leads to multi-organ failure and death. And this is to show you, to give you impression, these are the decoys. That's how we think Ebola evades from the immune system. In general, as shown here by Town and McElroy, blood titers of Ebola virus strongly correlate with disease severity and outcome. Ebola virus RNA copy levels in the blood increase logarithmically during the acute phase of the illness, and RNA copy levels in blood from patients who have died have been found to be higher than the levels in patients who have survived. This is not only true for Ebola, it is shown, or this correlation exists for many other diseases like HIV, like dengue, influenza, or the Marburg virus. And as the infection progresses, the immune system is unable to respond to the high amount of virus and is quickly overwhelmed. This leads to life-threatening viral disease with signs and symptoms similar to sepsis, like endothelial dysfunction and multi-organ failure. And the only proven current medical intervention that appears to improve patient outcome in this situation is supportive care to allow time for the person's immune system to respond to the infection. In such patients, CRT, high volume hemofiltration, coupled plasma filtration and absorption, as well as other extracorporeal techniques have been used not only to manage multi-organ failure or uremic syndromes derived from kidney injury, but also to restore hemostasis of the immune system. And if we assume a delicate equilibrium between the viral load and the immunological system, the eradication of viral infection may be realized only by tipping the balance in favor to the innate immune response by lowering the circulating viral particles. And if we consider dialysis membranes, most of these membranes, as shown here, will contain the virus, even if we use high cutoff membranes. On the other side, the virus will pass easily through a plasma filter with a pore size of 200 nanometers. And over the last 15 years, Medical has been developing a novel form of extracorporeal virus elimination named the hemopurifier, with the aim to extract virus and viral particles from the blood. This process is called lectin affinity plasmapheresis and goes back on the concept of affinity chromatography back in the 1970s. This is the device. Lectin affinity plasmapheresis combines plasma separation with virus and glycoprotein capture by Galanthus nivalis agglutinin, abbreviated here as GNA, in the extracapillary space of a plasma filter. This GNA, the active ingredient in the affinity matrix, falls into a class of biomolecules called lectins. GNA is derived from the common snowdrop, is composed of 4 identical subunits, each having 3 sugar binding sites, which are specific for mannose. And this specificity to mannose-rich glycoproteins provides this device with a dual benefit of action. On the one hand, lectin affinity plasmapheresis is able to bind and extract the whole viron, and by doing so, those virons may be not more able to infect other cells, and the damage could be limited. On the other hand, GNA binds the free-floating glycoproteins, which are the cause for the immunosuppression. And as the technique is, the extracapillary space is filled with lectin-based affinity matrix, and as the blood is perfused through the device, a resistance to flow is created, with the pressure drop above the length of the fiber, with the pressure being highest at the blood inlet, which leads to filtration, and with this filtration of the plasma to the resin, and all the virus are captured in the extracapillary space. The pressure at the outlet is lower, and the plasma filters back. It's the same backward-forward phenomenon we know from hemofilter devices. The result is that every virus is remained back in the extracapillary space, attached on the resin, while no other component of the blood, for example immunoglobulins, will go back to the patient. The polyvalent activity of the hemopurifier has been confirmed by its effectiveness against viruses for which there are no effective protective or therapeutic agents, some during in vivo clinical studies and all with in vitro testing, for example the Ebola virus, Zika virus, smallpox-related virus, chikungunya, the swine flu, the bird flu, even the reconstructed Spanish flu of 1918, Lassa dengue, as well as HIV, Marburg, the Marburg virus, the MERS coronavirus, and hepatitis C. The following 2 slides only to show you the efficiency that has been measured during in vitro experiments with miniaturized versions of the hemopurifier. This one's for the removal of different Ebola strains from tissue cultures performed at the CDC. This one for the clearance of the soluble glycoproteins from cell culture supernatants. But also we have some in vivo data. The up to date there was 3 clinical studies who were performed in India who proved the concept, and these studies documented safety and feasibility of the device in more than 100 treatments in patients with HIV and hepatitis C. And attracted by these data in 2014, my colleague Benjamin Koch, and with the support of Professor Ronco and Rod Kenley from Esler Medical, we had the opportunity to test this device in a critically ill patient infected with Ebola who was airlifted to the containment unit in University Hospital. And I will show you some impressions from this. Our patient was a 38-year-old doctor from Uganda who was admitted to our special isolation unit on the 3rd of October 2014. 5 days earlier, he had developed fever and had been tested positive for Ebola virus. His clinical condition at arrival was marked by fevers, chills, abdominal pain, vomiting, and diarrhea. Supportive therapy and intensive care treatment under biosafety level 4 conditions included balanced volume therapy, antipyretic, antiemetics, analgesic medication, and besides different experimental therapies we tested, his condition worsened further, and he went into multi-organ failure, and which made intubation and mechanical ventilation necessary. Also, he developed acute anuric kidney injury, and renal replacement therapy was started on the 9th day. 4 days later, after approval of the German regulatory authorities, we performed lectin-affinity plasmapheresis with the aim to lower viral load and the glycoproteins. For this treatment, we did incorporate the hemopurifier in the existing dialysis circuit upstream of the dialyzer in the arterial line, performed anticoagulation using regional citrate anticoagulation with a Fresenius multifiltrate CITSA system as depicted here. And as you see here, this was at the beginning of the treatment with the blood flowing through the hemopurifier, just entering the dialyzer. Only to document the mode and the prescribed dialysis dose has not been changed, and moreover there was no clotting and no hemolysis, and in this 6.5 hour treatment no adverse event. This was the hemopurifier after the treatment, and as a result we were able to lower the blood viral load by binding Ebola viruses to the lectin binding sites of the membrane during this single treatment. But moreover, as presumed, Western blotting confirmed that in addition to the elimination of more than 250 million Ebola virus copies, soluble glycoprotein and shed glycoprotein were also removed. This is the BSL-4 lab in Marburg, the reference laboratory for filoviruses. And as shown in this graphic, with our treatment added here on the 13th day, along with a decrease in the viral load, is the red, an increase of the Ebola immune globulin titer, which already started in the 11th day, increased further, and in our experience, we at least did not interfere with the evolving immune response. Finally, our patient made a full recovery. And coming back to the question, because we were so impressed of the capability of this device, we further investigated the potential, and recently our group published data on in vitro studies on the effectiveness or the efficacy of Middle East respiratory syndrome, coronavirus, and Marburg virus glycoprotein elimination. Both the MERS pseudovirus and Marburg virus glycoproteins were passed through mini devices of the hemopurifier, and we measured the samples every 30 minutes And in conclusion, for the MERS coronavirus, we could show a reduction of up to 80%, and for the Marburg virus glycoproteins up to 70%. This is an infectivity assay, and the infectivity was reduced to almost 20 to 40%. Also, Aslan generated some in vitro data. Last year, the FDA-approved safety study was just been finished in end-stage renal disease patients with hepatitis C virus. Hepatitis C, again, was used as a surrogate for the broad array of pathogen A, category A pathogens for the future use. In total, 6 treatments per patient over 2 weeks during the regular dialysis session were performed. No device-related adverse event was noted, and based on these data, the FDA granted the hemopurifier an expedited access pathway designation for the treatment of life-threatening, highly glycosylated viruses that are not addressed with an approved treatment. And by this, the hemopurifier fits well in the list of the top pathogens in the list from the World Health Organization of top emerging pathogens, which likely cause severe outbreaks in the near future and for which few or no medical countermeasures exist. As you see here, no vaccines, only for Ebola to date under clinical investigation, no specific treatment. The hemopurifier was tested in almost all of these viruses. Besides viral elimination, we heard yesterday a good talk about extravesicular vesicles. Cells talk in a language that looks like viruses, and exosomes, a class of extracellular vesicles released by cells with a size range between 40 and 150 nanometers with a lipid bilayer membrane. Although the physiological role remains unclear, there are some, maybe they play a role in facilitating tumorigenesis. Exosomes are captured by lectins, and further research is ongoing to demonstrate a potential role for lectin affinity plasmapheresis in exosome removal. And to conclude, lectin affinity plasmapheresis is safe and feasible and a promising new supportive tool not only for Ebola virus disease, and I believe rapid reduction of viremia using an extracorporeal device has at least 2 potential benefits. By quickly reducing viral and glycoprotein load below a fertility threshold, it should be possible to provide additional time for supportive treatment and prevent further damage while the immune response evolves. And maybe rapid reduction of viral titer could also amplify the effects of new antiviral drugs. So, thank you for your attention.